My name is Abigail Coleman, and the purpose of this presentation is to provide a brief overview of normal deglutition, dysphagia, populations affected by dysphagia, formal and informal diagnostic techniques, and treatment methods. Okay, so another name for swallowing is deglutition, and this involves the transportation of liquids, solids, and salivas from the mouth to the stomach. And then listed below are the 4 stages: the oral prep, oral, pharyngeal, and esophageal stage of swallowing. So the main purpose of the oral prep stage is to form a bolus. So this includes the biting and gyratory and lateral movement of the mandible and tongue, as well as mixing the crushed food with saliva. Once the chewed material is shaped into a bolus, it is positioned on the medial furrow of the tongue against the hard palate in preparation to begin the next stage of the swallow. The next stage is the oral stage, and the main purpose of this stage is to transfer material from the mouth to the oropharynx, and this is completed by sequential anterior to posterior rolling tongue movements to propel the bolus backwards. This is a voluntary stage, and it takes between 0.9 and 1.5 seconds to complete. The next stage is the pharyngeal stage, and this is initiated as the bolus begins to pass any point between the anterior faucial arches. During this phase, the velopharyngeal port is closed to prevent material from entering the nasal cavity. The hyoid bone moves anteriorly and superiorly. The larynx closes to prevent foreign material from entering the trachea and lungs. The cricopharyngeal and upper esophageal sphincter are open to generate pressure. For airway protection, you have movement of the arytenoids to the base of the epiglottis, adduction of the vocal folds, and retroversion of the epiglottis to close the laryngeal vestibule. The stage is involuntary, and it has an apnea period, which is the reciprocal relationship between swallowing and aspiration to permit a safe transport of materials from the oral cavity to the pharynx. And the last stage is the esophageal stage, which involves the bolus making its way through the upper esophageal sphincter, esophagus, lower esophageal sphincter, and into the stomach via peristaltic waves, which take roughly 8 to 20 seconds to complete and is involuntary. Right, so the cranial nerves in deglutition include the trigeminal, facial, glossopharyngeal, vagus, accessory, and hypoglossal nerve, and these nerves innervate the muscles of the pharynx, tongue, larynx, neck, face, and head. And you'll see below are listed each cranial nerve's involvement in these stages of the swallow, as well as the NTS and NA, which make up the swallowing center, and they are responsible for sensory input and motor command. Okay, so dysphagia is difficulty in transporting solids or liquids from the oral cavity to the stomach. Dysphagia may occur in individuals of all age groups and in varying degrees of severity. The geriatric population holds the highest prevalence of dysphagia. Abnormal swallowing patterns may occur in any stage of the swallowing and may result from behavioral, sensory, and/or motor deficits. And dysphagia is the consequence of one or more pre-existing diseases or pathologies and does not occur in isolation. Okay, so listed are the 7 clinical indicators of dysphagia, and they include dysphonia, dysarthria, abnormal gag reflex, abnormal volitional cough, cough after swallow, voice change after completion of a swallow, and abnormal tongue movement. And some signs and symptoms of dysphagia. The most common are coughing, a wet vocal quality, and throat clearing. And it's important to know that while those are the most common, 40% of aspiration is not identified on a clinical bedside exam. So therefore, just because a sign or symptom may not be observed doesn't mean a person isn't suffering from dysphagia. Other signs include excessive secretions or drooling, food pocketing in the mouth, changes in respiration, nasal regurgitation, and vomiting. So the complications that occur due to dysphagia can be very serious and even life-threatening. They include aspiration pneumonia, choking or near-like choking, dehydration, weight loss, and malnutrition. So aspiration pneumonia develops after inhalation of colonized oropharyngeal material. And then listed below is aspiration pneumonitis, which is an acute lung injury after inhalation of regurgitated gastric contents. So these can occur if a person is suffering from dysphagia. So some deviant swallowing effects are premature spillage, which is when the bolus spills over the base of the tongue before the pharyngeal swallow is triggered. Pharyngeal residue, which is when material remains in the hypopharynx after a swallow has been completed, and it's more than just a coating. Laryngeal penetration, which is when the bolus enters the endolarynx and remains above the true and false vocal folds and on the laryngeal portion of the epiglottis. And then aspiration is when material passes below the true vocal folds and into the airway. So a person can aspirate at 4 different times during a swallow, and that'll be before, during, at the height of a swallow, and after a swallow. So a person may aspirate before a swallow due to premature spillage and poor coordination of the timing of structures involved. They may aspirate during a swallow due to reduced laryngeal elevation and delayed or weakened epiglottis retroflexion. They may aspirate at the height of a swallow, which is attributed to reduced laryngeal closure. They may aspirate after swallow due to flowing or dwelling residue in the hypopharynx. And 90% of individuals aspirate before or after a pharyngeal swallow. Alright, so the clinical bedside exam. Sorry about that. The clinical bedside exam is a non-instrumental exam of swallowing, and this should include a thorough review of medical and psychosocial history, and followed by a physical exam. So the major components include the patient's reason for referral. Is it timely? And is there a physician who ordered it? Their medical history. Have they been noted coughing, choking after eating or drinking? Or have they lost a lot of weight recently? And then medications, if they're on any that may affect swallowing function. The patient's mental status, if they're alert, their posture, if it's safe for the clinician to administer a bedside exam. It may be postponed until the proper aids are put in place. Dentition is important to consider. The status of their dentition. If they have dentures, it's important to make sure that they fit and they're adhesive to the gums. Their oromotor sensory functioning. So you must assess their range of motion of the tongues, lips, and mandible. Their vocal quality. It's important to note if there's any changes before, during, and after eating and drinking. And their respiration, if they're on oxygen, as well as their respiratory rate. So after assessing the previously mentioned components, it is then time to consider whether or not the patient is a candidate for moving forward into the feeding aspect of the evaluation. If they are, the SLP must assess feeding status, mealtime behavior, orientation and reception to utensils, lip closure, mastication abilities, oral transport of liquids and solids, if they swallow poorly chewed food or have pooling of food and liquids in the oral cavity. If the patient is not a candidate for food or NPO, then the SLP may defer further assessment and reevaluate at a later time and or recommend exercises. It's important to know that an SLP uses the exam to assess swallowing function, but it's not a diagnosis of an underlying cause or disease. So, in brief, Logeman listed the 5 reasons for administering a clinical evaluation of a swallowing disorder. So the first formal instrument for evaluating swallowing is the fiber optic endoscopic evaluation of swallowing. And this evaluation allows visualization of the larynx before the swallow, the onset of the swallow, and post-swallow. It's a comprehensive 3-part exam that evaluates the anatomy and physiology of structures, the patient's swallow, food, and liquid, as well as their response to therapeutic intervention. The next is the video fluoroscopic swallowing exam, or should it say exam of swallowing, or VFSS, and it's commonly referred to as the modified barium swallow. And the purpose of this is to study the anatomy and physiology of the oral preparatory, oral, pharyngeal, and esophageal phases of swallowing. And if aspiration occurs, you can focus on the reason, and so appropriate treatment can be initiated. So it's a frame-by-frame analysis, which allows for assessment of all stages of the swallow. You can look at bolus transfer time, motility problems, and etiology of the swallowing. And you're able to use a variety of food types, so liquids, solids, etc. Some disorders and diagnoses that are related to dysphagia include stroke, TBI, spinal cord injury, dementia, neurogenic diseases, myasthenia gravis, cancer of the head, neck, and mouth, and pulmonary and cardiopulmonary conditions. So some immediate dysphagia interventions include changing the consistency of the food, changing their liquids, providing small mouthfuls, prompting a second swallow, putting in place of pacing techniques, using adaptive equipment, and changing the mealtime environment. So the goal of treatment in dysphagia is to ensure that the patient can consume enough food and liquid to remain nourished without posing a threat to their airway safety. The treatment can be indirect or direct. Direct treatment is actually engaging the patient with food and using strategies and postures, while indirect treatment is for patients who are not candidates to use food during therapy, and you'll work on strength, range of motion, etc. So postural treatments include changing the patient's head or body posture, which can be effective in eliminating aspiration. Posturing techniques redirect food flow and change pharyngeal dimensions in systematic ways, and these are generally used temporarily. The postures include chin down, chin up, head rotation, head tilt, lying down, and side lying. And then some dysphagia maneuvers. So you have the supraglottic, which closes the vocal folds by voluntarily holding one's breath before and during a swallow in order to protect the airway. And then following with a volitional cough. Then you have the supraglottic, which is designed to voluntarily move the arytenoids anteriorly, closing the entrance to the laryngeal vestibule before and during the swallow. You have an effortful swallow, which increases posterior tongue-based movement to facilitate bolus clearance. The patient is told to swallow and push hard with the tongue against the hard palate. And then you have the Mendelssohn maneuver, which is designed to elevate the larynx and open the esophagus during the swallow. The patient holds the larynx in an elevated position during the hyolaryngeal elevation. And then here are my references. Thank you very much.